Well, my name's Ali, and I am an F2 working in Portsmouth at the moment. I'm going to be talking to you guys about esophageal cancer. Most of the things I'm going to say are already included in the slides, but I'll try and talk through some of the more difficult concepts. Let's start. So, I've included quite a lot of detail in these slides. It's by no means necessary to learn everything written down. It's more for those interested in surgery or aiming to do well in their exams. But if you do stick with it, you'll have a very good, solid foundation for esophageal cancer. So, before we start, I'm just going to say how important it is to learn things in terms of classifications. This is important, especially in OSCEs and oral examinations, and it'll be appropriate for you for the rest of your career. For example, if someone asks you how you investigate for cancer, you don't just say, I'm going to do an MRI straight away. You'd start with bedside examinations, bloods, imaging, and then move on to invasive procedures such as biopsy. I've set out the slides in this way where appropriate, so hopefully it'll help you with your learning. So on this slide, we can see the investigations classified, starting with from bedside and then moving on last to the interventional or invasive procedures. So at the bedside, you start with history and exam. Blood, you look for anemia and also just look at the albumin. Imaging, what I haven't written down is a chest X-ray, so you can, but all you really see sometimes is a widened mediastinum, but it can exclude other causes. You can also do a barium swallow if you're worried about things such as achalasia, and also to visualize the extent of the stenosis of the lumen from the cancer. The most important ones are the staging scans. You do a CT cap initially. This isn't good for visualizing small cancers of the esophagus, but you can see big ones, and also some metastases. Most patients will undergo a PET scan, so this is used to determine stage and shows where the distal metastases throughout the body are. Moving on to invasive or interventional procedures, all patients will undergo an OGD and a biopsy will be taken. This will show us the grade. Most patients in most centers will also undergo a diagnostic laparoscopy. So this is a laparoscopy where washout is done. The washout fluid is recollected and analyzed for the presence of malignant cells. So if you're in an exam and the examiner asks you, how are you going to investigate this patient? You're going to say, so I'd start at the bedside. History and exam, take the height and weight, calculate the BMI to get an indication of nutrition status. I'd move on to bloods, full blood count, bone profile, U's and E's, look at albumin, anemia, and kidney function. Moving on to imaging, the most important things would be to ascertain staging. This would involve a CT, chest, abdomen, pelvis, and also a PET scan. Finally, to determine the grade, I could do a OGD and take a biopsy and analyze this with histology for the grade and also a diagnostic laparoscopy showing the presence of malignant cells in the peritoneal fluid. If you say these, especially the diagnostic lap and the PET CT, the examiner will know that you have some idea about esophageal cancer, you know what you're talking about. So, a very important slide now. Whenever you're asked about the management of any condition, like I said, you always classify it. But for cancer specifically, you should always say this phrase, and I want you to learn this for the rest of your career. Management of any malignancy will be guided by both its stage and its grade. So, you know all the TNM staging systems you always skip past when you're revising, and to be honest, everyone does. I do that all the time. That is what actually guides the management of almost all malignancies. Stage is more important in terms of grade, but the take-home message for this slide is make sure you say that phrase, and the examiner is going to be like, whoa, this guy's good. On this slide, we have the TNM scoring system for esophageal cancer. I've never learned this. The only one I recommend you learn for exams is Duke's criteria for colon cancer. So, like I said, management will be guided by stage and grade. So here's the list of managements as the stage is increasing of the diagnosis via the TNM scoring system. So if we have a small sized tumor, less than T1A, you do endoscopic resection. So OGD, identify the tumor, resect it, and that's it, done. If it's larger with not too much metastases, you can do an esophagectomy. Depending on the size and invasion, you may do chemo or radio beforehand. And finally, if it's too advanced, you get on to non-surgical management, so chemotherapy, radiotherapy, or palliative measures. So if you're in an exam situation, you'd say, so my management would be guided by stage and grade. For for us low-scoring cancers, this could begin with endoscopic resection. Moving on, esophagectomies plus minus chemoradiotherapy. And finally, for advanced cancers, supportive treatment, systemic chemotherapy, or palliative measures if appropriate. So the first one is endoscopic resection. Most patients that present are far beyond this stage, but it's important to know about. So the intent is curative and it's for cancers that are small and localized to the muscularis mucosa or the lamina propria. There's several techniques. So an OGD is done. From there, the cancer can be excised or it can be ablated. Ablation can either be happened by cryotherapy, where it's frozen, or radiofrequency, where a probe is inserted, radiofrequency waves are released, which heats up the cancer, killing the cells. The most important thing for this is that close follow-up is required just to make sure resection margins are adequate and recurrence does not occur. Esophagectomy is a massive operation, first of all. Esophagectomy is performed for localized disease, but it is also performed if patients have local or regional lymph node invasion. So if there's distant lymph node invasion, say in the groin, then esophagectomy is not the case, but for para-aortic lymph nodes, for example, that's all right. Like I said, it's a massive operation. All patients require ITU admission post-op. There's several techniques and approaches. It's good to know about these in case an esophagectomy patient comes up in your exam. So Ivor Lewis, this is typically done for distal esophageal cancers, although this is an oversimplification. It's a two-stage. You remember that because Ivor Lewis has two names, double barrel, and the stages are a right thoracotomy and an abdominal incision. The abdominal incision is usually a rooftop incision or can be a midline lap. McKeown is a three-stage procedure, which also includes a neck incision, and then there's various laparoscopic assisted techniques. It's important to know most patients will have a chest drain inserted to prevent pneumothorax from the thoracotomy, and also most patients will have a feeding jejunostomy inserted for feeding post-operatively. So on this slide, there is a diagram illustrating the different approaches for esophagectomy. And the reason I've included this is because esophagectomy patients do often come up in finals. And it's because it's a patient with interesting scars you might not see in normal practice. And the surgeons are rightfully so very proud of their work. So on the far left, we have the Ivor Lewis. So you'll have a midline laparotomy or a rooftop incision and a right thoracotomy. Usually the right thoracotomy is more posterior around the back. So in an abdo exam, if you're doing one, once you're looking at the lymph nodes, you make them lean forward and have a look. If you see a thoracotomy in an abdo exam, you can just assume most likely it's an esophagectomy, or the patient was a cardiothoracic patient at some point. Next, we have the McKeown. So McKeown is similar to the Ivor Lewis, except there's an incision in the neck. Now, not all neck incisions are longitudinal, like we see in this picture. Some are transverse, which makes it difficult to pick up in patients who are a bit more healthy in their neck folds. And yeah, so if you keep an eye out for this, if you see a patient who you think has had an Ivor Lewis, just make sure you give a really show the examiner that you're looking at the neck. Just exclude McKeown and they'll think you know what you're doing. Slide shows an esophagectomy where the anastomosis is done using the stomach, which is the most common technique. So part of the stomach is excised, the stomach is mobilized, the diaphragmatic hiatus, sorry, and an anastomosis is performed between an esophagus and the stomach in this case. Other other conduits you can use include the jejunum and the transverse colon. So, chemoradiotherapy can be used as neoadjuvant, as a precursor to curative esophagectomy. Shrink the tumor down and then chop it out. It can be used in the first line for patients who are not fit for an operation or not wanting an operation, and also it can be used in non-curative patients to prolong life. Symptomatic relief procedures. So often patients present who don't really want chemoradiotherapy, or they've had theirs and they don't want any more, or they've attempted radiotherapy to shrink the tumor but they don't want an operation. The cancer grows and it becomes very difficult to have a good quality of life because of the dysphagia and the pain. So in these cases, there's certain interventional procedures you can do, namely balloon expansion or a stent insertion. So an OGD is done, the obstruction is identified, and then either a balloon is used to expand the lumen or a stent is inserted to keep the lumen open and patent. These have their own complications and risks, for example, perforation of the esophagus or migration or infection. So like I said before, the prognosis in esophageal cancer is poor. 5-year survivals are written here. Basically, you don't need to know these, just appreciate that the cancer presents late. The operative treatment is a massive operation with significant post-op complications, and recurrence rates are very high. The last slide we saw a case which I couldn't be bothered narrating. Here's the focused part of the case, so the important things. So the age, the fact he's male, he's got weight loss, he's got progressive dysphagia, alarm bells ringing in your head. This guy's got esophageal cancer. Other risk factors, he's obese, he's got a smoking and drinking history. So really, you're like, oh, this guy's got esophageal cancer. So your differentials in this case. Anytime you're presenting a differential on a case of obstruction or dysmotility, it should always be related to the lumen, the wall, and outside the wall. If you're not learning it like this, or you're being taught not being taught like this, then you're being taught wrong. So your differentials for dysphagia in this case. Intraluminal, inside the esophagus itself. So a food bolus being stuck there can cause dysphagia. Intramural, inside the wall. You can then subclassify this into benign or malignant. Benign causes could be strictures, esophagitis, trauma, for example, from an OGD, or a web associated with Plummer-Vinson syndrome. There's also pharyngeal pouches as well you can mention. Malignant causes would be esophageal or gastric cancer. And finally, extramural, so outside the walls of the esophagus itself. This can be a large lung cancer, for example, in the bronchi, mediastinal lymphadenopathy, thoracic aortic aneurysm, or a hiatus hernia. So the important thing though is just to make sure you classify obstruction, dysphagia like this. If you do like this in an exam rather than infection, inflammation, and malignancy, this is more of a surgical sieve, it's more of a surgical classification, and it's very impressive, especially as a medical student to do this. So the examiner asks you how you're going to investigate this patient. It's exactly how I've written it there. You know how to do it now. Just remember to classify. So the examiner moves on to management. You take a deep breath in and you say, the management for this patient would be guided by the stage and grade of his malignancy. His case would be discussed at the MDT, and management options would include blah blah blah, whatever you already know. That's all you need to say. So the take home points. The most important things are to learn definitions smoothly, so you don't pause, you don't think, and you can remember them for the rest of your life. The next thing is to revise things in terms of classifications. This includes causes, investigations, and management. Last and most important thing is to be confident in yourself. Take a deep breath in. Try not to sound too boring like I am right now, and you'll be grand. The take-home points for esophageal cancer specifically. So it presents late and has a poor prognosis. It's good to note the differences between adenocarcinoma and SCC, namely Barrett's esophagus, and remember that management is guided by staging and grading, alongside patient factors. Thank you. Hope this was somewhat useful for you. If you do have any questions, please do feel free to email me. And if you have any feedback, that would also be appreciated.